Welcome back, everybody. We've had to juggle things around, as you know, but we're nothing if not agile. So for this next session, this is called The Stars in Our Galaxy. One of our stars is missing this morning, but the three that the two out of the three that you'll hear from this morning are lived experience advisors, and they are Gary Sutcliffe and Kororia Johns. And I'll get them to introduce themselves. Fire Merle, who many of you would have seen and heard from, and realized the influence she's had in our Mahi, is unavailable this morning, and we're just trying to check that she is okay. So our plan is for Kororia and Gary to introduce themselves a little further and share, and then we've actually got the recording of Fire Merle. Some of you may have seen it, but it's still worth watching. There's absolute gold in the 6-minute Becca Whanonatanga video that she recorded for us. So over to you, Gary.
Kia ora, Amajit. Thank you. Thank you. And Kororia, kia ora koutou. Ko Gary Sutcliffe toko ingoa, I noho ana aho ki Waitakere, ki Tāmaki Makaurau. My name's Gary. I'm from Auckland. I've been married for 47 years. I have 2 children and 5 delightful granddaughters. Look, I am, for the most part, semi-retired. Some people listening to me that know me will probably maybe have a chuckle about that, but I am, for the most part, semi-retired. I've spent the last 17 years of my working life in the health sector. My work and passion is in consumer advocacy. It's around authentic consumer engagement and co-design of health services, and in telling my story so that some can relate to my journey through mental health challenges and others can be better informed. My health challenge story started in the early 1990s, and I experienced depression and anxiety related to an impending business failure. I found it difficult to accept that the business that I'd worked in for so long and committed so much to was heading down the gurgler. My initial contact was with my GP, who I'd known for about 5 years. I'm just trying to describe him without being derogatory, but he was quite a stiff man and not that easy to connect with. After trying an antidepressant that didn't work, I was then referred to a psychiatrist. And I thought, why on earth would I need a psychiatrist? They were for crazy people, those unfortunate people in mental health institutions. That's how little I knew at that time. However, despite that day of the referral being one of the worst days of my life, the psychiatrist was easier to relate to. And after our first consult, which as a matter of interest cost $200, which was a fortune 30 years ago, particularly when one of your stressors was financial, the psychiatrist prescribed an antidepressant that she said that she would know within 2 weeks, if not earlier, that it was going to work, which was quite a relief, as my wife and I had both heard people saying, look, it could take over a month, 6 weeks or more, for medications to start working. I didn't need to hear that. At our second appointment, despite me saying that I thought I was feeling better, I wasn't really. And she picked that up pretty quickly. She then described a medication called nortriptyline. I can't remember what the first one was called that didn't work. And after a few weeks, I did start to see some improvement, some light at the end of a pretty dark tunnel. Over the next 10 to 15 years, I did experience relapses a couple of times, but they were relatively short-lived, certainly compared to the first months and months of recovery. On each occasion, the relapses were work-related stresses, totally. They all had to do with work or people that I was working with. And after a period of voluntary work in the mental health sector, I left nearly 20 years of working in the health sector, in the sports sector, and I landed a job in mental health in 2004 as a consumer development leader with an Auckland-based NGO mental health service provider. After a promising start, after about 18 months, I had conflict with the CEO, resulting in my resignation, and that caused me another relapse. After a brief period of unemployment, I met with the CEO of another organisation who I'd known for quite some time, and she asked me to come and work for her and to help her embed a consumer-focused ethos into her organisation, bring that consumer focus more forward than it had been. That proved to be a great opportunity for me, as well as for the organisation, and just helped restore my faith in working in mental health, because it needed restoring. I went on to work for another couple of NGOs over the next 4 to 5 years. When a project I was managing concluded, I switched to working in primary health and joining Dr. David Kadire and his wellness support team, which is what it's called now, at Tamaki Health back in 2013 as a peer support specialist. While I was there, I trained as a self-management facilitator leader and also as a health coach. These were amongst the best years of my working life. And considering that I flipped from the sports sector to the health sector at the age of 55, when some people are probably thinking, I think I'll just tail down my working life and head towards retirement. It was just the opposite for me, really. And while at Tamaki Health, I met Dr. Janine Bycroft from Health Navigator. And Janine asked me if I'd coordinate a new consumer advisory service and a contract that they had just secured with the Ministry of Health. I was only working part-time at Tamaki Health, which has suited me. Part-time worked for me. And so I also took on this role in March 2015. And I continue to do this role today. I love the mahi, being involved in some of the assignments. Some of them have been ongoing governance roles, and encouraging and mentoring other people and using their lived experience of long-term conditions to inform services as part of quality improvement and the development of new services. Last year, I joined Whae Merle, who I'd worked alongside at Tamaki Health on the governance board of healthcare homes, now collaborative at Aotearoa. I very much like what I see and how I feel about the work of the collective and the model of care, which has gone through at least one iteration in the 18 months or so that I've been there. And it's adopted by many medical practices. I've lost count of how many, but across Aotearoa. And the importance that they place, that the collaborative place on authentic consumer engagement. I had added the word consumer/patient engagement, but listening to Andrew talk about the only time you're a patient is when you're unconscious, which I love, that engagement and participation, involvement is of course paramount to me. It really strikes a big part of me as to what's most important in this area. So kia ora, thank you for listening to my story. Tēnā koutou, tēnā koutou, tēnā tātou katoa.
Ngā mihi, Gary. And Karoria, do you like to share?
Kia ora koutou. Ko mangatani wha tōku maunga, ko hokianga tōku moana, ko tāpapa tōku awa, ko nā toki matawhaurua tōku waka, ko nā pui me te raroa ngā iwi, ko Sibley Barber, ko Eva Wharepapa Morgan tōku kaumātua, ko Karoria Johns tōku ingoa, kia mihi kia koutou katoa. Kia ora everybody, I'm Karoria. I am currently sitting in Cable Bay in Te Tai Tokerau, in a very fortunate position at the moment, unlike a lot of my whānau here. So I'm incredibly grateful for the opportunity to speak to you today, not only in relation of my own journey, but in relation of the journeys that I see around me. My most meaningful engagements with the medical system particularly began when I was 11. I was a very bright child. Initially didn't have that many problems at school, but as I progressed through the education system, it became clear there were issues, and that on top of some whānau complexity meant that by the age of 11, I was engaging with the family court system and what was then social welfare. As a result of that, I ended up in state care even though the rest eventually ended up institutionalized because I couldn't find a place for a 15-year-old girl. As a result of my lack of engagement with the education system, my lack of diagnosis or support in the medical system, I ended up leaving mainstream society, if you like, and diverting into my first job where I was a striptease and burlesque performer. And actually that career carried me around the world, and I did 27 years and I did a really good job of it. But that kind of fringe dwelling, if you like, slightly outside the mainstream, really meant that I didn't engage with anything in the system in a way that was meaningful or helpful to me. I've had several quite severe interactions with EDs, mental health departments, respite facilities. I have a history of self-harm and suicide, quite substantial periods of substance abuse, including methamphetamine, and a real desire to want to figure out what was really going on behind the antidepressants that would work for a while and the interventions that would work for a while. I actually wanted to change things up. And so I started engaging on social media with a group of autistic people. And through that social media interaction and a bit of my own research, I ended up pushing for a reassessment for a diagnosis I'd received as a very young teenager. And it turns out I don't have borderline personality disorder with narcissistic tendencies and depression and anxiety. It turns out I'm undiagnosed ADHD. And so with the shift away from all of the medications that I were on, which were at sometimes huge amounts, and going on to methylphenidate, life has taken a massive turn. And I'm currently going through another issue with my health, because I've now, when I was young, I was diagnosed as possibly having endometriosis, but don't worry about it, because when you have a baby, it'll all resolve. As a result, I was never able to conceive, never received any support around that. And now that I've hit perimenopause, I've been diagnosed with, there's a medical term that I'm sure you clinicians know, adenomyosis, I think it's called. And what I'm finding is that it's having a massive, massive interaction with the methylphenidate. And that's become ineffective certain days of the month. What I've currently just let my last GP go over is that his response to that is, no, I'm not comfortable giving you more pills. Look at your history. You have a drug abuse history and we can't help that. So I've literally been shut down by him. So I'm seeking other help in terms of my general practitioner care. The reason I wanted to share the detail around my story is that I believe the intent of the health reforms, and certainly the support of organisations like the Collaborative, will mean that real joined up kind of care. Because I believe that first and foremost, when it comes to our rangatahi, the people who know them best are their teachers, their educators, their sports coaches, and they also might have an understanding of the family dynamic. So if we can get this kind of joined up care model working properly, it literally means that any door is the right door. Because one of the things that I'm very fond of saying, and Amaji and Gary, I know, will support me in this, I may not remember anything you said, but I will always remember how you made me feel. And I think that what we need to do in relation to supporting particularly primary care in the locality space moving forward is enable more connection between those cross-sector kind of multidisciplinary communication. So the teachers understand the kids. There's a straightforward conduit through to the healthcare professionals in their locality, or the whānau or support in their locality, to be able to allow them to work as a team in that wellbeing wheel and start to address some of the concerns that are putting other pressures on the family, so they actually have the time and capacity to enable a full engagement with their primary care providers. If you're worried about putting Kai on the table, the last thing you're thinking about is your own health. If you're worried about money, you're trying to run little Tama through for his asthma medication and you want to get baby's colic checked, the last thing that happens for you is you prioritize your own health. the unfortunate thing in that is that because it's then left at an acute stage, that mum's dying early and leaving her whānau without a mum. So, you know, I really want to reinforce that whole, what I call korowai care, which is the wraparound of the entire whānau, because I know that if one of my teachers had recognised what was going on for me, I wouldn't be here. My life would be very different. I'd probably be tertiary educated, and I certainly wouldn't be having the struggles that I have now. So I wanted to share my story because I think it's really important that we look beyond what's sitting on the surface, because people are only ever going to deal with what's right in front of them and is very acute. But if we can start to deal with that kind of wider picture for people, what we start to do is create a proactive environment. And because they're feeling more empowered, they're more self-determined, that whole consumer engagement thing goes away, and they actually start to feel like they're mana motahake and they have sovereignty and choice, and they want to actively, they will seek to engage with you rather than the other way around. So yeah, I just kind of wanted to share my story to illustrate how any one of those sectors at any time could have been the appropriate intervention and steered me on a very different path. I'm very fortunate that I'm sitting here now, because I don't believe that many people who have had a journey like mine have either lived long enough or found themselves in a position where they're focused and articulate enough to share that story in a way that helps to inform and empower others. So yeah, I just wanted to share that all with you, and I hope you can find some value in that. And I'm certainly available to help support any of the work that the collaborative has done, because they've been incredibly supportive in helping me and supporting me. So kia ora team. Tēnā koutou katoa.
Kia ora. Those, you know, both Gary and Claudia, just very powerful stories to share. And Claudia said to me earlier, you know, we each have a journey and a story to tell. And I think the more, you know, it's just coming back to what we've said earlier, the more we share, the more we learn. And, you know, I feel very privileged to be working alongside Claudia and Gary and keeping us honest on our journey, you know, so that we're keeping it real in terms of what we do and being able to share like this today, basically. We do want to, we still haven't able to check on via Merle. We're keeping checking, but we haven't heard back. We do want to play that video, but before that, you know, are there any questions? I know, Elizabeth, you talked about wanting to know, if, you know, wanting some support in terms of the consumer engagement by your practice. You know, there could be some certainly sharing in that space in terms of how to go about that, and we've got lots of resources there too. But just want to open the floor. Are you happy with that, Claudia and Gary, in terms of opening the floor? Yeah, so you know, obviously some wonderful comments coming through there, but yeah, would love to hear from others.
And can I just actually offer up, Amaji, that you know, it doesn't matter your background or your socioeconomic status or anything. You know, you could be living in the most wonderfully privileged situation. Your challenges are just going to be different, right? That's just the story of the human condition. And I guess what I'd love to hear about from other people is what were their challenges, and how might the intervention that would have supported them to have a different outcome have looked? Where would it have come from? How could we engineer that moving forward in a korowai care locality-based model?
I'm happy to, you know, I don't often or haven't really done a sharing of my journey, but in terms of what's relevant for me right now is what drives me to make a difference. And that has come from, you know, back in the UK, being a family, well, parents, 10 children. So I always say to my mum, goodness, you know, how did you manage 10 children? Highly deprived, in the sense of, you know, I make a joke of it now, and I think it's what gives you real strength of character in terms of your background. But that whole, you know, the social system bringing you Christmas presents, you know, so, you know, there were definitely worse scenarios than ours. But I think what that's driven me to make changes for others. And I think that Karoria talked earlier as well about, you know, what's the light bulb that goes on. And for me, the light bulb as a child was being able to have a good friend who showed me there was another way, you know. And I say to her to this day, because she was my best friend at school, and we're still connected by the wonderful Facebook, you know. I said, if it wasn't for her and her family, I would have taken a very different path. Because at the school that I went to, because I had many siblings before me, I was one of 10, the youngest, as I say, but they put me in quite a, you know, low grade and said, oh, you're just one of that family. So they automatically had the bias there. And then that shocked me into going, whoa, I need to make some change. So I worked really hard, got to the top set and, you know, excelled. But had the light switch not gone on. But I guess that what drives me now is then obviously love the area of health, love the area of, you know, the health and well-being of whānau grassroots level, you know, and how, so I'm really passionate about the locality space. And if we do justice to that locality's grassroots engagement, then, you know, we'll be, going on the right path. But, you know, things in our community, you know, creating initiatives for young people where it's early intervention, so allowing them to have that light bulb switch on. And then within schools, you know, people have heard me talk about, you know, with my volunteer hat on, schools know their whānau, they know what's happening. And so creating that whānau order approach within a school in terms of creating a hub to get that sort of, you know, support at the top of the cliff as opposed to the bottom. So I think, you know, our journeys of sharing create space for us to then go, how do I make my difference, you know? And I think working with Karoria and Gary, we see that all the time, you know, what is the difference that they want to make, and they are hugely, you know. So, you know, so we invite you to share, you know.
Don't be shy.
I'm not going to pick on anyone for this one, but
I think people are stunned, Amajit. They're stunned, you know. It's
but, Judy's got her hand up there. And Helen.
Oh, good, perfect.
I'll start my video so people can see who I am, if you can.
Hi, Judy.
Hi, Karoria. Thank you so much. I'm just fascinated because, you know, I arrived as a migrant to New Zealand, and I did teacher training, and I was very aware in a secondary school of, simply because I arrived having done a master's in neuropsychological research looking at the scholastic assessment of the school-aged child. And I was very aware of how many children I was seeing who were clearly in need of extra help in a variety of ways, and completely oblivious as to how that could be linked into the health system. So my comments are from a variety of perspectives, but basically, I mean, I know that basically that early intervention absolutely is critical. I don't know how empowered teachers are in terms of their education and training to inform them that it's really important that they link with health providers, because I think that there's a complete blockage there. But also as a mother who's supported a daughter with mental health, her own mental health journey, and part of that is to do with conception, going through IVF, having a whole variety of challenges along that way. I was locked out of being able to interact with her health providers because I was told that this was something between the health provider and the patient, and they weren't interested. They shut the family out. And so that to me is the challenge as well.
That's powerful. That's certainly that education health interface. We're optimistic that that will improve, but it is vital. We're all serving the same whānau in terms of that health and well-being, and finding those connections is going to be quite key. Helen.
Morena koutou. It's always hard to follow such brave and courageous stories. So Gloria and Gary, thank you for that. I just wanted to throw out a couple of observations. Firstly, to fess up that I came on this morning to listen to Sylvia, and it's a real bonus for me that she hasn't turned up, because I wouldn't have heard all the speakers this morning that I found so valuable and reconnected with some people. So thank you. I guess just an observation. I think that we're hearing this morning about, oh, you probably can't hear me because I've got my thing up there. Is that better?
Okay.
I've actually stopped using the term social determinants of health, and that's not because I don't think they're incredibly important and they're actually an important focus. But if we just use the language of social determinants, it assumes that the relationship between our work or our schooling and our health is a one-way drive in which our school and our working lives and our family affects our health. And yes, it does. But the way in which, when I've heard all our speakers this morning describe the impacts of our health on the rest of our lives. And so collaboration for health, looking at the health impacts of, the impacts of our health on the rest of our lives, thinking about that important relationship and interrelationship, and the wellbeing wheel, I think, is really helpful for that. So I think the social determinants of health language is getting in the way of our ability to transform the system, because it only positions a lot of the things that are really important to us on one side. And I think it stops us thinking about what is the role of the health system, the way in which we offer health treatments, and how that will then have a knock-on effect on someone's life. So if we take somebody out of the workplace to treat them, if we exclude people's whānau from that care, that has a knock-on effect. And so the way in which we offer our health services and the way we train our health workforce about how we look at the broader person. So I love the korowai care, but I just think, thinking that through, I would really value. And I do think that as soon as we call something social determinants, we say that must be the Ministry of Social Development over there to you. So I guess also, lastly, I would like to see us stretch ourselves and move out of our traditional train tracks. We could potentially say, measure whether we've supported somebody to resume school or return to work or stay at work through our health treatment. And MSD and the schools think about how quickly they access health, mental health and wider health treatment. Let's think differently about the way we measure and to help the systems move out of our traditional ways of working. So it's lovely to be here.
One of the things that, one of the relatively new things that's happening that will enable that is having your health coaches working alongside your health professionals in a clinic, health coaches, health improvement professionals, because we know that GPs are strained for time, that if you're lucky, you get 15 minutes, unless you book a double appointment and pay double the price. If you've got somebody with lived experience, whatever that might be, it doesn't need to be mental health, but somebody that they can take down the corridor and say, hey, here's Helen, she can help you with something that she's more conversant with, whatever, with other things, whether it be employment or housing or WINS or anything in the non-medical sense. And we're hearing terrific. So I'm not sure how many practices around New Zealand actually have health coaches now, but it'll be well over 200. It's probably more like 300 now. And that's where it's kind of like that one-stop shop, that integrated sort of care, so that when somebody leaves that practice. Yes, they might have been there for an hour or more even to talk with other people. At least they walk out of there with more than just a prescription in their hand. Kia ora, Helen.
And I mean, it's interesting you talk about the language around social determinants of health, Helen, because I absolutely hear what you're saying. It becomes a very compartmentalized conversation in certain parts of the system. I think that where the potential gain from using social determinants of health comes from is that the only way, I live in Te Tai Tokerau, I have 106 cousins by birth. Now, some of them have married 2 or 3 times, right? So I've got lots of whānau. And a vast majority, like in our takiwā, we have 70% no internet connections in those homes, and 25% are unable to get a cell phone signal. They have to drive to the top of the hill or whatever to get it, right? So, you know, when I think about the social determinants of health, and I think about their and my own incredibly distrustful relationship with anything to do with health. When I was first introduced to the concept of the social determinants of health, what that allowed me to understand was how, for example, if I wanted to get my 81-year-old dad to stop, you know, suffering from digital vision strain and actually get off his ass and do something and support himself to live a healthier lifestyle, what I had to do was connect to the things that mattered to him. And that was only ever going to be something social. I'm not going to do something because my doctor said so, because, you know, we've been having that same conversation for 10 years and I still haven't done anything. But when someone like a hip coach can connect with, well, actually, I'd really like to get to my granddaughter's graduation, that's something that matters to me. And I think the social determinants of health conversation can really support whānau to understand how what a clinician is saying connects to what means something in my life. Otherwise, it's just blah, blah that I get at the doctor's appointment and I ignore it for the 50th time in a row, right? Having said that, I do actually relate to what you're saying in I'm going to say the clinician space. So I definitely empathize with you there. The other thing that I think, you know, when we're talking about, for example, schools and the formation of localities, I think that I absolutely agree with your, you know, we need to get off the single track thinking kind of train and start to explore what kind of access can the school and the primary care create together. So one of the things that I have been looking into recently is what would, like if I wanted to improve, you know, for example, I've been asked to do a project and they're looking at linking it into a patient portal system. And I just said to them, if your target is Māori men between 40 and 55 in Te Tai Tokerau, I can promise you not one of them is going to take it up because they're working 14-hour days on a logging track. They can't get a cell phone signal. They don't, I don't even use my patient portal. They're not going to use it, right? What would be meaningful for them in their whānau is if they had, for example, free Wi-Fi at the marae. So any day they could, like the kids can zoom into school from the car park if they need to, they can, and in that space, there's a health hub type computer set up. And one day it might be a health coach, and one day it might be a whānau or a navigator, and one day it might be a nurse practitioner. And what it does is it provides that sort of consistency of someone being there all the time, but a variety of services that are available on different days that are accessible. And through the digital gateway, they're enabled and supported to learn and use those gateways. And I think because what happens is, like, I've got an elderly man who I keep an eye on in Whangarei, and he doesn't like his doctor, he doesn't like his nurse, he really doesn't like his housekeeper, but he loves his podiatrist. I've got other whānau here who are not enrolled, and they are literally using their chemist to manage their long-term conditions, because the chemist has always got a smile for them, always got time to talk to them, always available, not when they've got an appointment, but whenever it suits them to go in, right? And that kind of accessibility is really, and they just don't have the trust in that kind of set appointment system type thing, right? There was a wonderful initiative done in Redfern in Sydney 5 years ago or so. And they had a slum ghetto in Redfern. All the Aboriginal people had been transported there and dumped into these 3 big apartments, and it was just a ghetto right in the middle of town. And they took one of the ground floor units and they gutted it, and they put a housing representative, a New South Wales health representative, a Ministry of Education representative, and they put all of these people in the same office every day. And they actually linked into intergenerational registration of whānau. So, you know, one story was they had a woman who had 6 children taken away from her. And she presented the last time and they took her baby. Then they found out that she was pregnant again. And so this time she went walkabout at 14 weeks. But they stayed in touch with the rest of the whānau, and they made sure that she knew through the great way that they had a place ready for her and everything else. She not only kept that child, she got 2 of the rest, she got 2 of the others back, and she's working on the rest, you know, and it was just from having that team in the one spot. And so we don't have the workforce to roll that out. I mean, ideally you'd have that. We do have the workforce and capacity to roll different people through these community hubs as opposed to staying in our buildings. Because, yeah, I think I'm absolutely with you. We've got to get off that one track thinking. Kia ora.
Oh, kia ora. There are a couple of questions there for you, Gary and Karoria. One of them is, how do we engage and create space for grassroots involvement? So that is a challenge to us all right now. Gary, how do you feel about that one?
Sorry, just Rebecca, I was actually putting something in the chat when you mentioned that. Please repeat. Sorry.
That's all right. That's all good. How do we engage and create space for grassroots involvement?
Okay, so it's not as complicated as some people think it might be, and it's creating options for people who, in practices, I'm going to delete the word patients. Thank you, Andrew. To be able to give some feedback, more than just dropping a notice in the comments box or that sort of thing, but actively, proactively seeking some engagement and feedback in a number of different ways. And I think people respond to options. Not everybody, in fact, probably I'd argue only a minority of people actually like filling forms out. I'm one of those crazy people, but anyway, but you know, different options are face-to-face, maybe after they've had their consult, having somebody there that they can just pop in and say, look, how was your experience today? What did you know, how did you find it? Did you get the answers you needed and that sort of thing? So not unnecessarily prolonging the experience, but actually adding value.
Thank you. The other question we have is how
sorry, Amaji, I'm just going to bounce in there for a second and make a point that I make repeatedly. I think that personally for me, you know, and I love the idea of that primary care follow up, making sure that they understand, because it can be a bit intimidating for some of my whānau to sit with a doctor. But I think if you're going to go into a community setting and try and understand the community, you need to plan for consultation, not conversation, because this is going to be challenging, but I'm going to say it anyway, because I had it said to me. One of my whānau said, why would I go to a hui? All that happens in hui is they come along, they take what they want to inform their work, and they go away, and I never see them again. And she works in advocacy, and she actually put it down to another form of colonial rape, because they're just coming in, taking what they want and leaving. And what she said was, you know, if we're going to enter into a relationship, I want to be courted, not taken, right? And so to allow space for those ongoing conversations and to commit to turning up as a person who is absolutely committed to creating a trusted relationship, that's what I want, right? So it's a conversation, not a consultation. So kia ora.
Kia ora. Absolutely. I think, you know, trust and whakawhanaungatanga is everything. And we'll only get the shifts when people are feeling safe in those environments. And it's two-way, absolutely. conscious of our time, but the other question we have, which is absolutely important, is how do practices take the information from stories and translate it into action? How do we use that information for the betterment of all? And we're seeing some of that in action right now, but just, further thoughts on that, Karoria and Gary?
I don't know whether sorry,
Oh, sorry, Gary. No, you go. You go.
No, I'll bow to you and I'll come in out later.
I think probably the most important thing is that if someone's been vulnerable enough to share their story, ask them what they would want, because they're the one in the experience, they firsthand what it feels like, and they would have someone, they'll already have their own ideas that they're sharing with their family about, oh, but I wish it had been this, or I wish it had been that, or it would have helped me if, and ask them, follow it up with a question, because actually they know. One of the things that annoys me in this space is when I hear whānau stories and then they take the stories away and they distill them into what they think it means. It's just, so ask them. Ask them.
That's good, cool. Andrew, you've got your hand up.
I couldn't agree more with what Gary and Karoria are talking about, that, we're quite keen to ask those questions and actually engage and find out. It's scary to ask questions when you've got a pea shooter to deal with the answers. So at the moment, we have a health coach in our practice. It's only the very beginning of what we actually need to provide things that make people feel listened to, feel engaged and feel well. And we would want to walk back into our communities actually saying, we failed you. We've actually got a system that doesn't work for you. What does good look like for you? How do we actually humbly realise that we don't have the answers and we're not providing what people want? Very likely you'll find at a community level, there'll be stuff with MSD, other agencies, justice, housing, education, a whole lot of things that actually are really screaming the obvious. And I'd imagine a community board, in my view, if you ended up with a locality board, maybe have one or two health providers. The rest of the people would not be there. But your community leaders, your NGOs, your representatives, consumer representatives, and people with the ability to actually see the bigger picture and make things happen. So we'd love to ask those questions, and I think we should be asking them. But until we actually get over ourselves and realise that what we're currently doing isn't what's suited, then the stories will continue not to be resolved and will actually make people unhappy, both ends, provider and as consumers. But we need to realise that we are failing, and we need to start saying, well, if we're going to do this differently, we have to be braver and more courageous and get over ourselves to a large degree. But none of us are more important than the people we look after. And why would we not want for ourselves and our own whānau a wellbeing system? Just when we get crook or something's going wrong, what would we want? And we're not providing it at the moment.
We need to have you cloned, Andrew. I just think that the original question you came up with, Amajit, about how do you translate something. Actually, in a sense, it's not about translation. It's certainly not about interpretation. I think what the most powerful stories or one-liners or whatever they are is when you quote somebody in their own words, and then you pick up the key messages that come out of those words and how what they've said to you may impact on the service that you provide, good, bad, or indifferent, and then follow up. If they're good enough to have given you their time to give you that feedback, keep them involved, unless they specifically say, actually, that's all I want to say, don't contact me again. But I think most people would like to know, so how is what I've just said and conveyed going to make a difference? How will I know if it's made a difference? So anyway, but keep people informed and involved. Sorry, Amajit.
No, that's all good. And I often take the view that it's okay for us not to have all the answers. It is about that listening and feeling, what the needs are. So yeah, look, we could have actually had a whole day on our lived experience advisors, and just all of us are obviously have our own lived experience. So I do think, I know that Karoria, Gary and Kirsten have got ideas around that. So watch this space, because gathering that sort of input is going to be vital for the future. So thank you so much, and really appreciate it. We are hoping that Biomill is doing okay. We won't play the video right now, but it was sent out to you. If we get a gap later, we'll play that Whakawhanaungatanga video, but it was sent out in the email via from Kirsten on Friday. But it is worth watching. It really is just from the heart, you know, it is beautiful. But what we do is, I think we should stand up, kind of shake off a little, and then we'll jump straight into our next presentation, and we are working out where the next break's going to be. But I invite you just to kind of stand up and just, you know, stop, because yeah, sitting in a chair on Zoom at home is it's hard going, you know. So yeah, we all fall for it in our world. So yes. So obviously those with your cameras off, I'm assuming that you're, you know, on the move. But for this next presentation, we have Chiquita Henson, Chief Executive Think Hawora, and Febri Suharto. Hopefully I've pronounced that correctly. And she is a wellbeing coordinator working on the with Chiquita and her team in terms of OraKonnect. Now, OraKonnect is an initiative, one that really has embraced the collective impact approach, you know, and on the ground grassroots. And we've, as a collaborative, have been holding that, you know, in high esteem and sharing it. And so Chiquita and I, yeah, and we're very lucky to have Chiquita on our governance board as well. So we've really wanted to highlight this mahi because it's wonderful. So I'm going to hand over to you, Chiquita and Febri, to do further introductions of yourselves and take the floor.
Ata Maria koutou. Thank you, Armajit. Hopefully Febri and I can live up to the fantastic overview just there, but we're both delighted to be here. So ko Chiquita Henson tuku ingoa, and currently the Chief Executive of Think Hawora, and on my left is
Kia ora koutou. Ko Febri Suharto tuku ingoa. I am the REMA Wellbeing Coordinator working with former refugee and refugee-like migrant here at Mid Central.
excellent, and I'm going to share my screen. Oh, we're in the wrong spot. Right, can we see that? Yep, thumbs up. Thank you, Gary. So apologies, some of you may have seen some of these slides, but we promise that we won't give exactly the same presentation. It's the first time I've actually had the delight of co-presenting with Febri. And of course, with the world being rather busy and everything, we've done some slides separately. We've pulled them together, but we haven't practiced. So it might take half an hour, it might take 3, but I'm sure it won't. So we want to give you a high-level overview of our collective impact and action called OraKonnect. Really important though, before I start there, just to explain what Think Hawora is and our partners to Tihi. So we are a not-for-profit charitable trust, and we're on a new strategy. You'll see weaving behind me. Last time I presented, Gary asked me to send the weaving strategy to him. So if anyone's interested in the overall strategic direction of Think Hawora, I really encourage you to go to our website. But we recognised in 2019 that just working with our more mainstream and with our general practices is not the answer to connecting communities to wellbeing. We needed to much more broaden our scope and our horizon. And Te Tihi is an alliance of 9 iwi and Māori organisations that work across the same geographical area as us, which is the Mid-Central District region, population of 180,000. And Te Tihi provide our Māori health leadership and stewardship to Think Hawora. So as an organisation, I don't have a Director of Māori Health or a GM Māori. We partner with Te Tihi, and Te Tihi provide Māori health leadership and stewardship. I think it's a beautiful example of Te Reti o Waitangi in action. And we are proudly a tau iwi organisation, and Te Tihi is a proudly Māori organisation, and together we connect to make the magic happen. We're underpinned by 2 things, the Think Hawora strategy, and these are our strategic aims. weaving, and in our new strategy we talked about our commitment to Tiriti o Waitangi, and then sitting alongside alongside our strategy is Kawa Kawatia. If anyone's struggling to really understand how do you pragmatically make a difference around Māori health outcomes, I really encourage you to download Kawa Kawatia. It's got a really nice simple framework in there to pick up and to work with your people, your communities, and to make some tangible differences. This is just our website that I talked about earlier, and recently we jazzed this up a bit around our Connect Communities for Wellbeing. If you're wondering about where to go for care, we often hear from people it's so confusing about where do I actually access care in our community. So we've got this tahi rua toru wha rima unu type approach. Some of you may have heard me tell this story before, but I was presenting this to our own board when we launched the new strategy, and people were laughing, and I couldn't understand why they were laughing and not listening to me. But it turned out they were giggling at each other and saying emergency department, oh no, and that it was red in the back because they saw the word oh no, not unu as in six. And then just a couple of photos just to show you some of the other different work that we've been doing in our communities with our communities. So I really encourage you to have a look at our website. But today we're here really proudly to talk to you about OraKonnect. OraKonnect is the western southern suburbs of Palmerston North, postcode of 4412, and it's a well-known postcode now across our Palmerston North area. This is our opportunity here with this community to think about what do they want from health services. We've developed a number of integrated family healthcare centres across our rohi. We went from 44 general practices to 27 general practices, so we've scaled everyone up. When we talked to our community down here, they were very clear they didn't want big bricks and mortar. They wanted us in health and social services to get more connected and to work in partnership with them. So we didn't build bricks and mortar. We developed this concept of how do we really engage with communities and have true community participation. As you can see, our community here has a population of 30,000. We often describe it as young, brown and beautiful. And the community there are very happy that we describe this community as young, brown and beautiful. And it's made up of quite a number of different parts of the western southern suburbs. So you'll see Awapuni, there's a north, there's a west and there's a south. And you don't dare call Awapuni west, Awapuni north and vice versa because they're all very, very different. We then overlay our .loves data, which is great now that the Healthcare Home Collaborative is sponsoring and this for all our practices that are engaging in healthcare home with the data that's available from .loves data. And it really shows us quite a picture here and such great opportunity to work with our communities. So we've set up an alliance. The great thing with the alliance here, these are the 14 partners, and this alliance is led by Tangata Whenua, it's led by iwi, Danielle Harris, who's the CEO of Best Care Whakapaihoara Charitable Trust. And this is the group that have been meeting for quite some years now to develop this real program of action and really listening to the voice of the community about what the community wants us to do. Our overall framework that underpins it is the whānau water outcomes. And I think just when I came on before, I was hearing a conversation around let's not use that language, social determinants, because often that language does put us more in that negative framework and it's that sort of deficit type thinking, whereas the beauty of the whānau water outcomes is this is much more mana enhancing, it's much more strength based. And all the mahi that we do across Things Whole Water in partnership with Te Tuhi and our communities is using the whānau water outcomes. I often refer to them as the 7 sensational outcomes. And then we overlay this with the quadruple aim. And I heard Andrew Miller talk earlier this morning about the quadruple aim, and they're also really, really important. The OraKonnect space, though, is focusing on these 3 things: economic wealth and security, healthy lifestyles, and stewards of the environment. Collective impact. So we've got to know collective impact really well. Really want to mihi here to Armajit and the team for reaching out to Tamarack Institute, Sylvia, and we are so on the right track here. We are so on the right track using collective impact. That's a lot of words on one screen, but it's one that sits inside our strategy, and I nicked from Tamarack Institute because we're allowed to think anything in the world now. You don't have to ask permission anymore. And I think if you just sit there and just read everything, this is the zone and this is the place, and surely this is the mahi we all want to get involved in, because it's all very positive language again. So our journey, it's been a long journey. My key message to anyone that's embarking on collective impact and really want to do proper community engagement and participation, it's not a 6-month project, it's not a year project, it's a never-ending journey really. So 17, 18, we established the Alliance. 19, we've got the program of action up and running. We developed our first squad, which I'll talk about in a minute. We keep reviewing our objectives and our program of action. And then this year we've got really clever around club funding different aspects and different roles. And I think this is when you bring all the pūtea, all the dollars into the table and think about what it is we could do together, because we can't do it in isolation, particularly when money's so tight. These are our squads. So we work in a really agile way. We've got a number of projects up and running at the moment. This is the range of them here. We don't have time today to talk through all these, but really happy if anyone's interested in any to reach out to us, and happy to spend some time. The ones in particular that are really, really powerful is the whānau led. So often as health people and non-health people, we think we're there to fix the community and the community want X, but our whānau led ones are having really, really amazing impact. And the whānau are often asking, when's the next one, when's the next event, what can we arrange? But today I'm really, really proud to have February alongside me here, and she's going to talk about the mahi that we're doing in the Rima wellbeing aspect of the squad. Over to Rima. Over to February.
It's okay, people call me Rima too. So hello everyone. I'll be explaining about the Rima Wellbeing Squad. And before that, I want to explain a little bit about who is Rima, where did it start, how did it start? So it's an initiative that started exactly a year ago. Just had my anniversary on the 16th of November. Time flies so fast. So Rima, it was an initiative that started here at Whenkaura with the base of my research that I conduct in 2019 about former refugee accessing health services in Palmerston North. Rima started as an acronym for former refugee, internally displaced person, refugee-like migrant, and asylum seeker. Refugee-like migrant was a developing concept that I learned from other PHO that use that term, and I think it's a really good term to be more inclusive for the refugee-like migrant community. So a little bit about the former refugee. As everyone knows, it's an official status for someone who has been forced to flee their country of nationality due to well-founded fear of persecution. For the internally displaced person are someone who has been forced to flee, however, they remain within their country borders. And for refugee-like migrant is someone who came from a comparable country to New Zealand. So they come to New Zealand with different variety of visa status, could be like working visa, student visa, however, they have similar health needs. And our former refugee who came under the refugee support category, they also are categorized as the refugee-like migrant because they're not entitled for the services like our former refugee do. And asylum seeker are someone who has been seeking international protection, however, whose application for refugee status has not been determined. And beside this, Rima also means so many different things in different languages. So when I started this initiative and people start calling me as Rima, I didn't mind because Rima means a lot of different things in the community. For example, in Bahasa Melayu, because many of our community here speak in Bahasa Melayu, Rima means tiger, and it's a symbol of a strong, resilient community. In Bahasa Indonesia, it's a peaceful way of living. In Arabic, it's a symbol of deer, and it means that it's skillfully affecting change. And there's so many more. So if you're interested to know more of what Rima means in the community or what it means for the community, I'm happy to talk more about it because I can talk a long time about it. And this is just the demography of former refugee here in Palmerston. So they're mostly settled in Palmerston North and Fielding. In a total of 2,000 community, but just an overview, we have an annual quota, like New Zealand itself has 1,500 as in July 2020. And for that's for the former refugee. And we have 330 annual quota for our refugee family support category. We also have 200 yearly for our asylum seeker. And this is the main ethnicity here in Palmerston Northern Fielding. We have Karen, people from Myanmar, Burmese, as well as people from Myanmar, Rohingya, Bhutan, Palestinian, and Afghanistan. So this is a little bit of overview of the RIMA work program. It aims to connect the community for well-being through an improved participation, greater empowerment, and a more culturally inclusive healthcare experience. It looks into the rights-based and the strength-based, and again, it highlighted the importance of collective impact in the community. We are focusing in the network development, relationship management, data collection, bridging health barriers, and sustainability. As you see, the bridging health barriers, like we quietly, heavily highlighted, and the community are in the core of this program. So again, it's driven by the needs from the community, what they needed, especially the bridging health barriers. Yeah. So in the collective impact, we work in a squad, in the RIMA squad. We have like Ministry for Social Development, we have Tatihi on board, ETCLP, Manawatu Refugee Resettlement Forum, Manawatu Multicultural Council, and many more. So we really work together on how we can action the activities we have. So this is one of our activities. It's a community event. We have the World Refugee Day, we have a RIMA potluck, we have a community gathering with lots of very cool like culture performance. And in the World Refugee Day, we also have health stalls to again increase and have that connection with the community about, you know, health services that's available. And we also provide free flu vaccination. So in the photo of the left side, it's people like on the line doing the flu vax on that day. They were really excited to do it on the World Refugee Day. And that is a food from, that is our Indonesian nasi kuning, which is our yellow rice. In translation, it means yellow rice, but that is a symbol of celebration. So that was our launch of the program. And we were working alongside with the Manawatu Multicultural Council. And again, it was potluck. So we had some time to experience and enjoy food from around the world, which was really cool. Yeah, and we have more events coming. So we're now working with Mid Central DHB and Ministry for Ethnic Community to run the COVID-19 project, vaccination project. And this Saturday, we're going to have an event, which is a pop-up clinic for youth that is run by youth for youth. Which have like lots of prizes. It's a DIY carnival because we found that the community liked going to a carnival, and we try to make like a mini version of the carnival because we also want to be cautious about the social distancing and stuff. And this is our Rima Kuriro. It is on air at Manawatu People's Radio. Again, it is working in collaboration with Manawatu People Radio to promote, encourage health literacy, as well as access to health services for the Rima community. We also provide episode that is translated to different languages, as well as episode that is run by the community in their languages, talking about health and well-being services.
Really encourage you to go online.
Go on, yeah, that is the that is the link. This is our other project that we're working on, which is the RIMA Health and Disability Codes of Rights Easy Read version, because we found this is the most accessible version for the community, because it's easy read, very straightforward for them to understand their own rights. We also created a new template that will help them to understand better, you know, between the visual pictures and the rights itself. We have 6 translations so far. We're working with the community again to translate more. And we also want to do an audible version to support our Rohingya community because they only have spoken words. So yes, that is the Health and Disability Codes of Rights. And Chick mentioned a little bit about the Whanau-led project that we have, and this is one that was led by our Rima community who owns the barbershop, and he really just wants to go back and support the community by providing a free haircut. And we just have a video. Hopefully we can turn it on and share what happened that day.
Nothing happening yet, Chick. Are you seeing it on your screen, Chick and February? Maybe just message. It's the videos. Oh yeah, just getting some help.
I hear you're not seeing it.
No.
That's a shame. We'll get the link working and send it out on the clip. Apologies for that, Whanau.
Yeah, we were enjoying all the videos.
Yeah, we were enjoying it. We're bopping away to it all.
I was thinking you could see it and we couldn't, yeah.
Hold on, I'll just see if we can get back to where we were, because now I'm a bit lost in the old system. There we are.
Okay, so yeah, over to you again.
Yeah. So that was a real whirlwind trip of one of our squads in action, Rima. I'm personally extremely proud of this mahi. It all happened because February was working, or part of the Red Cross, somebody who sits on the DHB board and our chair of our consumer council, actually Gail Monroe, introduced me to February. And so we said, well, come on for a year and let's see if we can make some magic happen. And of course, we've signed her up to forever and ever and ever. And she's really showing us how to really work in partnership with people in a much different way than what we used to. And the amount of events that I've been to and the amount of yummy kai that I've had over the last year has been amazing, amazing. But really pivotal to the success is alliancing. I know in the health reforms, alliancing doesn't have a good frame at the moment. There seems to be some people that don't think that alliancing is the right way forward. My personal view is that alliancing is the right way forward. We can call it whatever we want to call it, but it is about getting people around around a table together and really thinking about their equal decision making and power. So if I'm in an organisation at $800 million, I don't have any more power than what Armajit does in the Healthcare Home Collaborative organisation, and we've got about 300K or something. But we've got the same sort of power. And the thing is, we can do that shared contribution and that equal decision making. So it removes all those power dynamics that goes on. And for so long in our structures that we're in, it's kind of the DHBs and the PHOs, even though PHO have been the power people in the rooms and the ones making all the decisions, and that's just got to go in these health reforms. Firm believer in the sensational 7 whānau order outcomes, and to help lift our language much more into that strength-based approach alongside the quadruple aim, because it's important that we do continue to provide really good evidence-based clinical care to partnership with our people. Collective impact, don't have to tell anyone that's the right approach, of course it is. But alongside it, really having that program of action and actually doing some mahi and keeping on going with that PDSA, please do something, anything. Plan, Do, Study, Act, whichever one you want to use, try, learn, adjust. There's so many different ones, but actually having that program of action, having that agile approach, and we found squads work really well. So each of those squads that we showed you are led up by someone different. So we at Think Co-Water lead the REMA piece, with February leading that out, and we're leading out the COVID readiness one as well. But all the other ones are led by different organisations, and that's that real way of getting good collaboration happening. That whānau-led, whānau-centred, so that whole concept of mana whānau, it's really got to be whānau-led. And I think whānau-led is actually a better language myself than whānau-centred. And then that community engagement, but more importantly, that true community participation, because we've all done a bit of lip service, I personally believe, across Aotearoa to community engagement. We've really got to shift and lift our game into that real community participation, find our people that know our community, part of our community, give them the putea, give them the thing. So February just does everything. It's like you do what you think you need to do, and every now and then she'll come to me, and somehow she gets money left, right, centre. She just got 16,000 from somewhere last week and something from somewhere else. Amazing, absolutely brilliant. So I just really want to mahi to you, e ho, and say you are amazing, and it's fantastic to work alongside you. And then I heard someone earlier this morning use this whakatauki as well. This is the one that underpins all the mahi that we do. So what is the greatest thing in the world? People, it's people, it's people. And Andrew, I picked up your wellbeing wheel when you were having a bit of a kōrero earlier too, and I was thinking it's really important that we do shift our gaze from that outcome type approach and really do start thinking about those other aspects of people's lives, so it's not just our sort of normal approach and everything. And then I'm going to stop sharing, and then February's going to answer any questions.
Wow, honestly, I take our hat off to you. That was just outstanding, and really the whole point is sharing that so everyone can steal your ideas and move them, so that we get the sort of collective gains. But opening the floor, questions for Chiquita and February. Andrew, did you have your hand up, or was that a got a few. Marie Lindia, let's go with you first, because Andrew's clapping. Oh, he's clapping. That's what he's doing.
I thought I was going to give him the floor first because he's doing nothing. Yeah, well done, Kapai, and it's really fantastic there. And from my volunteer work with ethnic migrants, former refugees, this one really relates right now. The key to success that they've shown, see that resources is not one of those, or even funding, because some of this, if you're a not-for-profit organization, funding is always one of those things that they need or they do success. So do you get funding directly from DHB or from the government, or do you have to apply, or you build it and they will come? How do you do?
Yeah.
How do you deal with with your programs? Because you got really amazing programs, and I could really I'm also part of multicultural Nelson Tasman here. So yeah,
we've got a real blended funding model at the moment, using predominantly the flexible funding pool that sits within a primary health organisation. So that's our base funding. February also has recently become a health coach in the HIP health coach type model. So we use some of that health coach funding to help fund February and the mahi that she's doing, because she's doing some individual and whānau and sort of community sort of leadership there. And then February's been like a little beaver and getting money from a few different places. And I think it's just now that people know that there's somewhere that they can go and want to do better for our former refugee REMA communities. People are, it is like you say, you can't build it, people come, but it's all little money. It's not big money by any stretch. The other great thing is having a REMA program under the OraKonnect umbrella has really helped us. So OraKonnect's really known and respected across Aotearoa, and having this as a squad has just given it that nice lift very nicely. So it works in the western southern suburbs, but as you saw, our people also live in Fielding as well as in Palmerston North. We're about to get some more people down on Portofenua. So it's not
Sorry, network support, Lucy speaking.
Oh, hello, Lucy.
Someone got it.
Yeah.
Someone's not muted and having a conversation. Yeah, okay.
Yeah.
Kia ora for that. Yeah, so you got the funding, you get health funding regularly, like what do you call it, a continuous one, and then you still have to apply. You got the base funding, and then you still have to apply for those small projects. Yeah, yeah, okay.
Yeah.
Yeah, kia ora.
And if you do have other questions, feel free to, you can email them to us. And, the engagement here doesn't stop, it can follow on. But absolutely, just reading Joe's comment, thank you for your leadership, Chiquita, in February. I think the Mahi is, just, as I say, outstanding, and we'll stay close so we can, as Andrew always puts it, pinch with pride the best ideas and then share them. So yeah, thank you for that. I will, I think we need to stretch our legs before we move into our next presenter, Jude McDonald, but maybe grab a cuppa, and then come back, and that'll allow Kirsten to have a break in the recording and then restart, so that we can sort of, when we send them out, it's not just one big huge